Hello. On behalf of the International Cardio-Oncology Society, I'm Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, and today ICOS presents highlights of a recent webinar. Our webinar relates to BTK inhibitors and hypertension. Today's presenters will include Dr. Emily Tomasulo of the Pennsylvania Hospital in Philadelphia, Pennsylvania, and Dr. Robert Copeland Halperin of Northwell Health System in New York City. Don't forget to make plans to visit Williamsburg, Virginia, October 5th through the 7th, 2026, for the Global Cardio-Oncology Summit. As many of you know, this is the premier cardio-oncology meeting, and we hope to see you there. So without further delay, please sit back and enjoy highlights from this recent webinar.
So we know that cardiovascular adverse events are a class effect of Bruton tyrosine kinase inhibitors. And while we have the most historical data relating to ibrutinib with cardiovascular adverse events, we also have direct comparisons between ibrutinib and acalabrutinib and ibrutinib and zanubrutinib, but no direct comparisons in randomized clinical trials comparing acalabrutinib and zanubrutinib. And this really poses a challenge for us as clinicians, as we're not frequently starting patients on ibrutinib in the front line in CLL and other lymphomas, but trying to tease out and parse out the data for the rates of hypertension and other cardiovascular AEs among all of the BTK inhibitors. So what we've included for you here is the longest available follow-up for the BTK inhibitor monotherapy drugs, noting that these are slightly different populations. So we'll start on the first row with ibrutinib. This study looked at an 8-year follow-up of patients with CLL and excluded those with 17p deletion, which is the highest genetic risk. And you can see an all-grade risk of hypertension of 25%. And then grade 3 or above, that incidence of grade 3 or above hypertension of 12%. And just as a reminder, grade 3 hypertension we define as a systolic blood pressure of 180 or higher, and or a diastolic blood pressure of 110 or higher. And so ibrutinib has the highest rates of hypertension of all of the BTK inhibitors. As we move down to acalabrutinib, that 6-year follow-up shows an all-grade hypertension risk of 11% and a grade 3 and above incidence of hypertension of 5%. And then zanubrutinib on the bottom line, you can see at the 5-year follow-up of patients specifically with a 17p deletion for CLL, the all-grade incidence of hypertension is 18%, and grade 3 and above hypertension of 8%. So, in the absence of direct head-to-head trials comparing acalabrutinib and zanubrutinib, it's really difficult to make conclusions about the relative incidence of hypertension. But in general, the way that I apply these data to my practice is that in patients who have risks for hypertension, I preferentially choose acalabrutinib, just given that it does seem to have a lower risk of hypertension, acknowledging that we don't have a head-to-head comparator.
And now the mechanism of BTK inhibitor-associated hypertension was initially, the framework for this was that it was mediated by off-target kinase inhibition rather than direct BTK blockade. But accumulating data suggests that on-target BTK inhibition may itself contribute to the development of hypertension through a network of interconnected signaling pathways. But regardless of the kinase that is inhibited here, it all seems to converge downstream when it comes to hypertension on nitric oxide bioavailability and endothelial homeostasis. And it's interesting to me because we know that endothelial homeostasis and nitric oxide bioavailability are also implicated in the mechanism of VEGF TKI hypertension, for example. But, BTK inhibitor-associated hypertension, at least in my experience, and especially with the newer generation agents, really doesn't behave at all like, bevacizumab-induced hypertension or lenvatinib. So I think there's still a lot more that we don't understand about this. And when it comes to the selectivity data, the newer generation BTK inhibitors definitely do demonstrate superior kinase selectivity. And newer agents like pirtobrutinib show even higher selectivity for BTK across more than 98% of the human kinome, over 100-fold selectivity relative to some of the other tested kinases. But a lot of criticism has been brought about these sort of assays because they're highly dependent on the type of assay that's used, and many of the kinome screens that are being presented here are using drug concentrations that are far excessive of what we see clinically. And so this can kind of lead to misleading conclusions about off-target effects and really what that means. And so a lot of these laboratory comparisons don't necessarily translate clinically into what we see in terms of observed toxicity. And I think this is a nice example of this. These are, as you said, hot off the press. These are the most recent data from ASH in December. And pirtobrutinib, this highly selective BTK inhibitor with a reversible non-covalent binding mechanism that was designed to overcome BTKI resistance. We didn't really have data until these had been patients treated in the first-line setting. All the patients who received pirto had received other BTK inhibitors previously, and this is for the first time showing first-line pirtobrutinib versus ibrutinib. And as you can see, the incidence of atrial fibrillation was certainly much less with pirtobrutinib compared to ibrutinib. And hypertension was also less, but not that much less. I mean, it's sort of on the same order of magnitude, which to me kind of flies in the face of this off-target kinase inhibition as being the primary driver here. And risabrutinib, which is used for ITP, also I thought was an interesting example because this is a very different patient population, the population with ITP compared to CLL patients who are older with more cardiac comorbidities. And in this phase 3 trial, there was no hypertension even reported or atrial fibrillation. This case, I wanted to bring in because I think the Easter egg here is this is a patient who has hypertension, but also in whom accelerated or exaggerated hypertension might be risky. And so how do we approach a case like this? This is a 67-year-old who has a history of hypertension, which is currently controlled, diabetes, and also a thoracic aortic aneurysm, which is being monitored and stable over the past years, chronic kidney disease, and also CLL with the 11q deletion, and now indications for treatment based on thrombocytopenia, lymphadenopathy, and symptoms. The blood pressure currently is controlled. The heart rate is normal, and the rhythm is regular. And the patient's also on several drugs already to manage the hypertension, a very good regimen. And in terms of this patient's medication list, the only sort of embarrassment I have here is I didn't include a statin, which of course the patient should be on the basis of his diabetes. And the potassium is slightly on the upper limit of normal in the setting of chronic renal insufficiency. And so, adding another agent like a mineralocorticoid, antagonist like spironolactone might be challenging here if the patient's blood pressure was to go up on a BTK inhibitor. And of course, we want to make sure that the hypertension remains controlled, given that the patient has kidney disease, so some already evidence of end organ damage, not to mention this aneurysm. So I think that, this is a patient in whom, some judgment would be required because it's not that, if the patient was to develop hypertension from a BTK inhibitor, it would be tricky to control it. Not that it wouldn't be possible. There's some things that could be done here, arguably, but it might be more difficult. And also, if this patient was walking around with blood pressures in 150s, 160s, we might be more concerned about that than we otherwise would, given the aneurysm and the other comorbidities. So what do you think we could do for this patient?
I'm going to go back one slide just to pull up the case again. So this patient, we selected these cases for a reason. They're challenging and they really require collaboration. The presence of these higher risk features like an 11q deletion, which is associated with shorter overall survival, and the unmutated immunoglobulin heavy chain make me want to involve a BTK inhibitor in their treatment. Um, I'm kind of paying close attention to looking at kind of whether or not the patient's on any antiplatelets or anticoagulants, and they're not. So I'm not as much kind of concerned with kind of risk of hemorrhage by the BTK inhibitor, but I think kind of risk of hypertension and atrial fibrillation are definitely things that I would take into account. I would think that a trial probably of acalabrutinib or zanubrutinib would be my preference. If their blood pressure is controlled, we don't know which BTK inhibitor is safest for them. It does seem that pirtobrutinib, although not available in the front line quite yet, available in the second line, does seem to have kind of a lower risk of cardiovascular adverse events compared with either acalabrutinib or zanubrutinib. But I think definitely a second generation kind of covalent BTK inhibitor would be my go-to in this patient. Can you educate me? I know, of course, with the thoracic aortic aneurysm, we have concerns about hypertension, but does the goal blood pressure change if a patient has an aortic aneurysm?
No, it doesn't necessarily change just on that basis, but I think, these are patients in whom we know that the risk of aneurysm expansion and ultimately rupture is directly mediated by blood pressure and arterial wall tension. So these are patients who blood pressure control is even more important. And there are some studies that suggest that beta blockers may be preferable in this context, but I don't think that the evidence is strong enough to recommend one antihypertensive class over another. It's interesting, I also put in here that the patient is on nebivolol, which is a beta blocker that has a sort of unique mechanism of action, and that it also has effects on endothelial nitric oxide activity. So, I don't know that anyone has looked into this, but it might be interesting to see how medications like this, and I don't know if others think about this at all when they're dealing with patients who are on TKIs and managing hypertension, whether this beta blocker might be a better choice than another based on the mechanisms that we know are involved here. I think if this patient needed to get a BTK inhibitor, we absolutely would go forward with it. And, just because, it would be challenging to control the blood pressure, there are options. And especially now with, technologies that are, becoming widely available, like renal sympathetic denervation and some of the newer agents like the endothelium antagonists, I think there would be, options if we were to get into trouble. So I don't think there'd be any absolute contraindication, but I think this is the kind of case where hypertension and that risk to me would come much more front of mind than in a patient just because they have, uncontrolled hypertension at baseline, especially in somebody who's on one agent, that regimen's just not even dialed in right. This is a patient, I think, that illustrates more of the challenges that we face in this multidisciplinary decision-making.
What an excellent presentation of didactic information and an outstanding case discussion on this very important topic. I hope you enjoyed it, and I also hope that you'll make plans to visit the Global Cardio-Oncology Summit, October 5th through the 7th, 2026, in Williamsburg, Virginia, in the United States. It should be an excellent meeting, and we hope to see everyone there. So for now, I'm Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society, saying, treat cancer, protect hearts.